Hello and welcome to the Community Voice. I'm Fara Sax. Welcome to today's show. We're going to discuss the evolution of Miami Vascular Specialists over the last 2 years, highlighting advancements in treatment and patient care. We'll cover the latest procedures for venous disease, the differences between thermal ablation and sclerotherapy, and how the CEAP classification aids in diagnosing. Joining us today is vascular specialist Dr. Tsoukas. Thank you so much for coming back.
Thank you, Farah. Thank you. It's been a while.
Yes, and there's so much.
Almost a year and a half since our last conversation.
Well, life has been good. You look refreshed.
Thank you. I appreciate that. And, I think dealing with venous problems helps a little bit. As I have told you before, I've switched shifted my arterial practice into more focused venous practice, and it does help with predictable hours. So it's a delight.
And you don't work alone. You are one of 7 mighty physicians, and then you have a support staff, and it goes on and on and on.
That's correct. And I would say we're 8 right now. We just recently hired another partner, because as we will discuss, the last couple of years since you left me, we have gotten very busy.
I have never left you. And, you've always been in my heart. We've always been working together.
Let me just say that it's always fun to come to Miami community newspapers, because it's low stress. It's almost like a friendly conversation we have here.
And we get to catch up on everything that's been going on in your practice.
It's really a delight. I appreciate it. I appreciate the invitation.
And I appreciate you sitting with me and being my guest today, and to tell our audience exactly what's going on. Let's talk about the main topic of what we're going to talk about today.
So the past couple of interviews we had, we discussed about the very common, superficial venous insufficiency. And this is a problem that affects millions of people. It's very,
what does that
very
really
common.
mean? Tell our audience what that really means in layman terms.
It really has to do with the visible varicose veins that we see in most people. I'd say if you look at anyone's leg over the age of 50, and I hate say I'm probably including that category, you will find some spider veins or a few varicose veins. It's a very, very common problem, but it doesn't really have severe. It has consequences. There is congestion, discomfort associated with it, but not the severe, sometimes limb-threatening consequences that severe venous disease can have. So we have discussed this sort of superficial venous insufficiency that we treat very commonly, very often, and we are very appreciative to have the patients for it. But also, today I thought we'll spend a little time discussing the less common but more severe cases of venous insufficiency that can be very consequential, for the quality of life and sometimes for the viability of the leg of the patient.
So you have 2 worlds of veins we're living in. We're talking about the ones that are less severe, and then we're talking about the ones that are more severe. So what we're going to talk about today is how your vein center has evolved over the last 2 years.
Correct. And I've prepared some slides for you today, and we'll just loosely go through them, and it's okay if we skip 1 or 2, but so I think I've showed you this before. This is our waiting room. So we decided that we would dedicate a part of our practice, including a dedicated waiting room for our vein patients. And we tried to be creative. Physicians are not always very creative in terms of design, but we did our best, to do a good job and make our patients feel warm and comfortable, when they come to see us.
So this is a more of a different side of the business or the practice, where people come in a different door and they can relax, unwind, and have time to just get centered before they come see one of your physicians.
We do see a big number of patients across the entire spectrum of arterial and venous disease, and we try to dedicate something in the venous arena, so to speak. And not only do we dedicate the waiting room, but also we have dedicated staff, a cell phone line that's dedicated to the vein patients.
And that number is 786-776-7866.
That's correct.
So it's different than the other side of the practice. So
we will show both numbers, just to be fair. So looking at our next slide, We do have, I wanted to show my staff. This is the dedicated team that we have for the vein patients. And just, sort of very briefly outline the type of procedures that we do for this superficial type of venous insufficiency. There are the main procedures that we do for the management involve ablation, thermal ablation, and sclerotherapy. On the top right, you see the vein close system that we use. There's nothing special about that. We just choose to use that system for many practical reasons. It's very efficient, and it has really simplified the management of superficial venous insufficiency. When I started my residency, I want to say 30 years ago.
Oh, don't date yourself.
I shouldn't be saying that, but we were doing these procedures in the operating room with anesthesia and so forth. Right now, we do them under local anesthesia in the office. It's a lot easier for us, a lot easier for the patient, of course. Very little downtime. The patients can walk immediately. They can climb up and down stairs the same day.
What has changed from the time before when you had to go under general versus when you can do a local?
The technology. Technology drives everything, right? So now we have thin catheters that we can insert in the vein with ultrasound guidance. And those thin catheters have a microwave tip that closes the vein from inside. So we don't really have to make an incision. It has really simplified things. A procedure that was, more taxing on the patient in terms of pain, recovery, blood loss has greatly been simplified by this procedure called ablation.
And it seems like people are up and running right away, or they need some downtime?
I wouldn't say running, but walking immediately.
I got to be literal. You're a doctor. I forgot.
Sorry. So,
no, I'm sorry. No, we're both sorry. Sorry.
So I asked them not to do anything vigorous for 5 days, just so they do not reperfuse the vein that we just closed. Not that this is a complication will occur or anything will break if they become a little bit more vigorous, but they might negate the work that we did. So just for precaution, we abstain from vigorous sports. If they were going to do a spinning class or run 5 miles, I would ask them to wait 5 days. But walking, driving the next day, going up and down stairs, they could do that immediately. So it's a big difference.
How do they know, or how does a patient know that there's a problem when they come to you? Is it that they're having pain? Is it that it's just doesn't look good? What is like one of those mayday signals?
Yeah, it's a little bit of both. So for this superficial kind that we were talking about, the venous insufficiency, as we will discuss, the CEAP classification are stages 1, 2, and 3. Mm-hmm. They would see something and feel something. The seeing part would be the dilated veins, what we call varicose veins. They could be tiny little thin spider-type veins, or a little bit bigger. We call them reticular, or true varicose veins when they're over 3-4 millimeters. And the symptomatology would be congestion, discomfort, itching, tiredness towards the end of the day after standing for a few hours at work, a long trip, a long car ride, a long plane ride. They would sort of exacerbate, these symptoms. Sharp pains, I always tell my patients that the sharp pains, the crampy type pains, are usually not associated with this superficial type of venous insufficiency. The legs are very complex structures. They have nerves, muscles, bones. Anything can produce pain. And you and I very well know that the etiology of pain can be very, very complex. So it's important to understand that, treating the veins can be very effective. It will mitigate symptoms like congestion, discomfort, itching. The very sharp, intense pains are usually related to spinal stenosis, arthritis, knee problems. And it's important to make that distinction to understand what expectations we have after treatment.
At Miami Vascular Specialists, you're able to understand you're able to differentiate if it's coming from the back, the knee, or the hip, or if it's just, not just, but if it is a vein problem.
Right. And yes, if I had to choose, I would pick the vein problem over the spinal stenosis, right? So Yeah, it's an easier problem to treat. And yes, we can make the distinction. We have a dedicated vascular lab that does, I'd say 10 on the average, 10 of these procedures every day, these evaluations. A very experienced technologist that looks at both legs of the patient, and they sort of give us a roadmap of their venous system with all the valves that are very important and the function of the valves, the degree of insufficiency and so forth. So by the end of the evaluation, a non-invasive ultrasound that we do.
I think it's on part of that slide. So let's see.
It is. So,
there.
yes, so we kind of forgot the slides, but that's okay. If we go to the next.
But you have an ultrasound there. You were looking at the ultrasound.
Oh, yes, we did. Yes.
Mm-hmm.
That's our dedicated vascular lab.
Mm-hmm.
It's the slide. Yes, it's on the...
Right, the left bottom.
The left bottom, yes. Thank you. And then on the next slide, I wanted to show the difference between thermal ablation and sclerotherapy. Sclerotherapy, again, for this superficial kind of venous insufficiency is key, because the catheter will be very directed, very deliberate and accurate way of closing a vein. In other words, anatomically, if we wanted to close a vein from point A to point B and know exactly the extent of the procedure, we would use the thermal catheter. It's the most reliable tool. But if we had a set of varicose veins that look like a tree, some of them actually do in the periphery, in the lower leg, the catheter doesn't have the capability of spreading itself among branches that sometimes can be convoluted, tortuous, and so forth. When we do sclerotherapy with foam, the foam actually spreads very nicely. And if we can identify the root or the trunk of that tree, we can do the injection, and it's actually very spectacular to see the foam spreading and the veins disappearing in front of your eyes. It's a sort of a cool procedure.
I can see you really like that.
Very, very satisfying to do this.
Do these particular veins come back? Is it like a one-time you do it and you're done for the duration, or do you have to continually have a maintenance?
That's a great question. So the ablation is effective 95% of the time within 5 years. The patients who tend to come back are usually the bigger patients, and I always warn my patients. I tell them that in a perfect world, we would do the treatment, and if they had extra pounds, they would work into losing those extra pounds in the next 2 or 3 years. Because the bigger patients, if you think about it, afford a lot of pressure on the iliac veins, on the veins that pass through the abdomen, trying to get to the heart. So the blood has a hard time getting through, and that difficulty is translated to elevated pressure. So the venous pressure, the venous system gets congested. That congestion leads to the body finding another pathway. One of my patients said it very well years ago. He said, "Doc, it's like water down the mountain. If you have a lot of pressure, you stop it here, you're happy for a few years, and then the body or the water finds another way, and you have new veins." So the bigger patients tend to come back 5, 7, 10 years down the road with more veins.
And what about, is heredity play a problem, play a factor?
Definitely. So this superficial type of venous insufficiency is almost always hereditary. If you think about it, you'll find someone in the family who had the same problem.
I'm in for it then.
It starts. so am I. I mean, it's very, very common.
But if that's my only problems, I'm pretty good, right?
Very common.
Let's talk about the difference between the thermal ablation and the sclerodermy, which we talked about there.
Yeah.
Is there more that you'd like to add to that?
Yes, I'm using sclerotherapy, foam sclerotherapy, more and more.
Foam
sclerotherapy.
So it's different than we would do the saline mixed with the other part of the cocktail. Is that?
They're different forms.
And when would you use each of them?
I prefer the foam when I have a bigger tree, so to speak, to cover bigger real estate or bigger area to cover, because the foam spreads nicely, and the bubble carries the medicine on its outer edge. So if you think about filling a tube with medicine, the center of the tube will not be affected by the medicine. The only part of the medicine that affects the tube is the outer edge. So if you have a bubble carrying that, you can use a lot less medicine and cover more area. So I find it, very effective. The bubble's going to travel and cover the entire tree. The only problem with foam is that it's a little less predictable as it spreads. So you cannot use it. I prefer not, actually. Physicians do use it, but I prefer not to use it near the groin where, we get into bigger veins and so forth. I prefer thermal ablation in that area.
Interesting. And you're located in Kendall, right in the Medical Arts in Baptist.
That's right. We're in the campus of Baptist Hospital in the furthest west edge. It's the Medical Arts building on the 5th floor. Since the last time we spoke, we have done about 1,000 patients, 1,000 cases.
Well, kudos to you and your team, your 8 mighty and support staff.
Thank you. And I thankfully I have a lot of help. And I'm getting more help. My young partner, you actually did an interview with Dr. Taubman, right?
Wonderful.
And she was great.
Wonderful and excited and loves talking, like you, loves talking about veins.
We are very passionate about our patients.
Absolutely. And you do a great job.
Thank you.
Very, very thorough.
I appreciate it.
We've also talked about mentioning expanding the treatment to more advanced problems of venous disease. Can you elaborate on that? I think we might even have a slide.
Yeah, we have always treated we call them the tougher, the more involved patients. And this is just, I don't expect anyone to remember this, right? This is even hard for physicians to remember.
I had to look it up.
The CF classification. But it was very instrumental in sort of establishing some order in this very diverse group of patients. So C stands for clinical, E is etiology, P is pathophysiology, and it gives us an idea. So from 1 to 6, the clinical part involves the superficial varicose, the spider veins, the more involved varicose veins. The 3s are when you have a little bit of swelling. The 4s, the 4, 5, and 6 groups are the ones that I was hoping to speak a little bit more about today. These are the patients that start having discoloration. The 5s are the ones that have had an ulcer in the past, when the skin kind of breaks down because of all the stretching, the swelling, and so forth. And the 6s are the ones that have an active ulcer. These are patients whose life is significantly impacted by this problem. Thankfully, they're a lot less common. They're a little bit harder to treat, and it's worth spending a little bit of time because through the years, if you treat the mild cases, of course, you will have some of the more involved cases. And we had the opportunity and the privilege to treat some of these patients with good success in most of them. I've had patients actually, I can think of 2 patients who have been seeing me since 2005. And I have lived through the entire evolution of problems, how, the problem reoccurs, and we have to get creative and do something new for them so that they can keep going. We can heal their ulcers and keep them being productive and happy, in their lives.
And how does it get from, you're talking about your 4, 5, and 6 patients as a classification that it's a way of communicating and documenting what their prognosis, what happened, why,
Right.
How do they get from it being not a problem to escalating to the 4, 5, and 6 classification?
That's even another great question. Thank you for asking that, because I also had a slide on the preventable risk factors, right? There are risk factors for this.
Are we going to talk about you want to pull up the slide of the risk factors?
Let's see if we can find it. Let's
risk.
Okay, so this may be, I will apologize for this picture, but it shows you some of the 4s, and the one on the right is a 6. This is an active ulcer. That's what they look like.
I always thought it was a skin condition, but it's not. It's really something that's going on under the skin in the veins that are causing these ulcerations, like an eruption.
That's correct. It's a little bit deeper. So the pressure of the veins impacts the quality of the skin. It produces inflammation. It produces pressure, swelling, stretching of the skin. The skin suffers. It is inflamed. It's itchy. It's painful most of the time. So it really gets bad for some of the
Why?
patients.
Why do people let it go from the not so great, but to the, like we were talking about, the 4, 5, and 6 classification?
So sometimes people have the opportunity to intervene, changing their lifestyles. Sometimes they don't. There are people who have some real hereditary problems.
Is this caused by is it caused by diabetes? Is it caused by heart problems? Is there a secondary problem that leads to this?
So bad congenital venous insufficiency, valvular insufficiency can cause this, and there's not really much that the patients could do about that other than try to manage it the best they can. But obesity can also lead to this, right? This is a preventable, being very overweight, the very obese or the morbidly obese patients tend to...
Alex, can you find the slide that actually talks about the factors? And then you can put it up, and then Dr. Tsoukas.
Let's see if we can...
I'm sorry, continue on.
Scroll into that. But there are risk factors.
Here we are. Thank you, Alex.
Thank you. So age, as we get older, we can't do very much about that.
Geez, really? I want to live forever.
In fact, as I say, it beats the alternative, right?
Yes.
But family history is a problem. History of deep vein thrombus can predispose into these more severe cases. Females tend to be a little bit more involved, but the ones on the bottom, the sedentary lifestyle, smoking and obesity, these are sort of preventable. Right. These are
they are.
These are things that we can do something about.
Right.
And I try to be gentle about that, because we all have stresses in our lives, and we all go through problems, and we can't always be in control. Sometimes control kind of eludes us, and we lose the handle we have on our lifestyle and our what we eat, and sometimes the smoking and so forth. But these are, by and large, things that we can do something about. So
why women? Why women are more susceptible to this? Because it said that on your slide, and I'm curious,
right?
And probably 50% of our viewers are women.
And why should that be? Because women gift us with children, right?
Thank you. We did something right?
They go through pregnancies.
Yes.
And anytime, just like when you are very obese, you have a lot of pressure on the iliac veins. The same thing happens with a pregnant uterus. The uterus for 9 months is pushing on those iliac veins, and is increasing the pressure on the lower leg. So if you had a patient who was already predisposed with bad valves or had a deep vein thrombus and went through a pregnancy, the condition, the venous problem, would be aggravated. And it's sort of something that goes with venous hypertension.
Is this also preventable by wearing compression stockings? Is that or is that a misnomer? Is that true?
Absolutely. If you ask me to raise my pants right now, I'm wearing a pair of compression stockings.
Going up is fine. Okay.
So, in fact, I show it to all of my patients. Most of these problems, if you had a crystal ball and you knew that in 20 years you develop venous insufficiency, what you do is you lose weight, you stop being sedentary, you start doing some cardio and walking. And just walking every day is enough.
And for patients that are limited mobility, perhaps in a wheelchair, are they at a higher risk of having these problems?
They are. In fact, the patients that the C4s, the skin discoloration, I see a lot of patients who are in wheelchairs or elderly patients who don't move very much, where the calf, we call it the calf muscle pump, is the pump that evacuates, brings the blood out of the leg towards the heart. Those calf muscles are all working as well. And you have what we call venous stasis and elevated pressure in the veins and all the bad things, the cascade that starts from there. Mm-hmm. So absolutely. Now, I have had several of these patients, and there are now little mini bikes on the market where you can actually sit on a chair and be sort of biking a little bit and exercising your calves. And those devices can be helpful to some of these sedentary patients.
That's wonderful. And we talked about, or we're going to talk about the perforated veins.
The perforators, yes.
And why.
Thank you for reminding me.
Why that's important in the venous disease, and what does that mean, and how are they connected?
Do you
have a slide on that?
I created the slide. Yeah, oh, yeah.
Alex, genius.
Thank you. Entirely apropos. So I created the slide and I forgot until you asked me. The more I look at these advanced stages of venous insufficiency, the more I find that on top of the superficial venous disease, the bad valves in the superficial veins, there are some of these perforating veins that are involved.
What does that mean? Because I'm looking at a lot of pretty colors, but I'm not understanding. So perhaps share that with me.
The picture on the left shows the deep vein centrally, the superficial vein on the right, and the sort of a bridging vein. It looks like a letter H. So the middle of the letter H is the perforating vein.
And what does that mean when it's perforated?
It means that it goes from the superficial end through the fascia, through the envelope of the muscles, through the muscles into the deep veins.
Oh, so that's where you get that pretty looking leg that looks like it's bulging. Is that what happens? It goes from, so in other words, you can go from like a regular little vein that could really grow into something because it's moved through the fascia.
Yes. So the vein doesn't really move, but it becomes bigger. It becomes more elongated. It kind of stretches like a balloon, and it starts pressing on the skin. So I find that these perforating veins are involved more and more, or I find it more and more. They were always involved, but I tend to notice it more and more that there are culprits, such as perforating veins, complicating the entire, the treatment, the picture. And the good news is that we can ablate perforating veins. We can do thermal ablation for them and sclerotherapy as well.
So these are treatable that way?
They are. We have to identify them. They're sometimes poorly shown in the regular duplex ultrasounds that we do. I have spoken to my technologists, and they pay special attention to these perforating veins. I find that very important.
And how long have you been doing this?
The vein work or the vascular
as
work?
a vascular specialist.
Oh, wow. Over 30 years. I finished my fellowship in 1998. No, it's almost 30 years.
30 years. What made you want to become a vascular surgeon? Did you because I could see you and Dr. Taubman, you just love veins. I mean, it's just like, it's all over you. It's inside. It's a calling. It's a mission. It's a fact finding. It's being able to find a solution to a problem.
Now that's an existential question you're asking. It's a tough question early in the morning, but but you have to care about other people, right? You have to have a genuine interest in helping other people, because the training is long. It can be grueling sometimes.
How long was your training?
We ended up spending 6 years in medical school, 6 years in residency, 2 years of fellowship before you can actually practice, right? So you're 30-something years old before you can actually say that you can do what it is that you do.
It's a long time to wait.
Yeah, it's a long time, and you have to have some degree of dedication, to go through that. And for me, and I think for most of my partners, most physicians I know, that's sparked for, interest to help the fellow human being. So we like to help. The other side of the coin, that it's very satisfying to start understanding pathophysiology and the way things work in the body, just to put it very simply. It's intriguing. It satisfies intellectual and scientific curiosity. So you have to be sort of mechanically and hydraulically inclined to like vascular surgery. I love hydraulics. I loved physics. It was sort of, it came very easy and intuitively to me.
It's a lot of work, though, to become where you are today. That's a lot of dedication.
I appreciate that.
Where'd you grow up?
It doesn't seem like that. So,
when you do what you love, I think it makes life so much easier, and it doesn't feel like
it goes
work.
faster.
and it comes from within, so it's satisfying.
Yeah, I appreciate. Thank you. I appreciate that.
Where'd you grow up?
So I grew up in Greece, right?
I know. Where in Greece were you?
But
It's a beautiful place.
I was, I love. I go back any chance I get, and I was in Athens, at one of the suburbs, and I went actually to medical school there. I started doing medical school in Greece. One of my professors asked me to do a PhD in Boston. I spent a couple of years there. And from there on, I was involved in a number of research projects. We were very productive those years. I ended up staying in Boston for my residency. And there I met my wife, Michelle. We never went back,
Mentor. Who's the person that influenced you the most in your life?
Oh, wow, that's a big question. There was a surgeon where I did my residency who made everything look easy. The very difficult cases that other people sort of kind of struggle through, he made them look very straightforward. And he made me realize that you have to spend time to prepare, you have to spend mental time with every surgery that you do or every procedure that you do beforehand, and also spend time after, thinking about it, how it could be better, how you could improve it, and so forth. He was a master of exposure. That's, I call him his attitude was one of patience, and he was very thoughtful, very controlled, never lost his calm. I was very inspired by him.
What was his name?
His name was Marvin Lopez. He was an oncological surgeon. Where I did I wonder if he's still practicing. Actually, I haven't spoken to him.
Maybe he'll be watching this and he'll go, "Oh my God,
Perhaps,
my patient, my protege is Dr. Tsoukas, and here he sits in Miami." You never know, right?
You never know. You never know.
And parting words, what would you like our audience to know as a final thought for future patients?
I prefer not to see you in my office. I'd rather you being well and not needing my services. So what I like to say is that what the choices that we make today will affect us 5-10 years from now. If you can, if you think about venous disease, a pair of compression stockings, losing a few pounds, eating a little bit less, moving a little bit more will prevent the bad stuff. The superficial things that is fun to treat and some of the cosmetic things, we can take care of that, and it's very easy. So if we wanted to do ourselves a favor, we would eat a little bit less, move a little bit more, wear a pair of compression stockings. We'll stay out of trouble.
Dr. Tsoukas, it's been a pleasure. And if you need more information about the Miami Vascular Specialists, their number is 786-776-7866. And also their website is miamivascular.com. Thank you so much, Dr. Tsoukas, for being my guest.
Always appreciate you, Farah.
Thank you so much. And thank you so much for joining me today on The Community Voice. Until next time, take care of yourselves and each other. Have a great day.